Hello all. Good morning to one and all. This is Nagraj from IIP Digital Media team. Today's topic is pain education for physiotherapists, physicians, patients, and caregiver. And today's speaker is Dr. Palasha Sardesai, and moderator was Dr. Mamta Karpe. And question and answer section that was overtaken by Riddhi Sampath. And this webinar was conducted by IIP Women's Health Council, Goa State. And without wasting much time, and I will hand over the session for Mamta Karpe ma'am. Thank you.
Thank you, Dr. Mamta. Good morning, everyone. I'm Dr. Mamta, your host for today's webinar. First and foremost, I'd like to thank IPWC for this opportunity on this platform. We have all experienced pain. Pain is an unpleasant feeling that signals something is not right. Our today's webinar is on pain education, and our speaker for the session is Dr. Palasha Sardesai. Dr. Palasha has done her BPT from School of Allied Health Sciences, Manipal University, Manipal. She has also done her MSc in Neuromusculoskeletal Physiotherapy from University of Nottingham, United Kingdom. She is a certified yoga therapist, taught Pilates instructor, manual therapist, and aquatherapist. Without any delay, I want to request Dr. Palasha to commence the webinar for today. Thank you. Dr. Palasha.
Thank you so much for the lovely introduction, Dr. Mamta. Good morning, everyone. Thank you so much for giving your time for this on Sunday for this webinar. So today's topic is pain education for the whole public, therapists, physicians, patients, and their families in general. I'm going to be telling you what this webinar is going to be entailing. So it's a simplified overview of what is pain, which is a complex process which occurs in our body. In case it's the processes which occur in our body are numerous. And there are many questions which come when people suffer through pain. Not every single one has the similar kind of pain. So without further ado, I'm going to start my webinar. So as you can see, the reason I'm starting this webinar is because to change the perception of pain, to give a representation, to give a label, name for our for the health problem, which could be pain, but could not be pain or could be pain due to extra sensitive nerves. And also, while for the treatment, for the management, it could help in reduction of fear avoidance behaviors in patients. So once you understand pain, you're halfway into the process of managing it. Because while many people I've noticed through my entire journey of physiotherapy, they want a one-time debit transaction as a pain relief and end up suffering because they realize it is not how it is supposed to be. And while you get that one-time debit transaction, which you think, but it's actually a credit transaction. So the bill keeps increasing and you have to pay the bill later on. So that is the whole cycle which gets repeated in pain. And lot of emotions get involved, definitely, because when you realize your expectations are not matching what the reality is, certain aspects collapse, basically. So this is the main question right now. What is pain? Yeah, we know pain is painful. What is pain? So according to the revised definition of IASP, which is the International Association of Research on Pain, this is a 2020 revised definition. So pain is an unpleasant sensory and emotional experience associated with or without an actual or potential tissue damage. So you don't actually need to have a pain, a tissue damage. You can still experience pain regardless. So pain is actually a personal and subjective experience, which is influenced by an unpleasant sense, by culture. It can be influenced by the attention. It can be influenced by the meaning of the situation where you are in. So it doesn't just begin with the stimulation of the receptors. Definitely there are stimulation of receptors, but what it does is instead the disease or the injury produces neural signals that enter an active nervous system, which is a mixture of personal and past experiences, cultural and environmental factors, which is what cognitive component is of pain. So this is how the pain is interpreted. It could be from our past experiences, current experiences, how it correlates. Next is the sensory and how the pain is perceived. So this could be where it is located, how much of intensity of the pain is, and the quality of the pain. So how usually in this it's mostly about you can definitely get to know how you're feeling. So this is the complaint, how you can tell what kind of pain you are having. And the lastly, which is a combination of cognitive and sensory, is affective component of pain. So now the brain coordinates an emotional storm to maintain these first two components. Now, we don't feel good when we are in pain. We typically feel negative emotions such as anger, sadness, fear, or frustration. And unsurprisingly, individuals suffering from chronic pain, long-term pain, persistent pain, can develop secondary symptoms such as depression or anxiety and furthermore, depression being a complex condition on its own can cause more physical symptoms. So how does pain take place? So pain, so you can see on this slide, I've written nociception. So what is nociception basically is, it's a neural process which encodes it. The process is basically translating unpleasant stimulus, like whatever stimulus your body perceives. So what nociception could definitely mean pain, but pain does not need to equate as nociception, because nociception can occur in the absence of pain, whereas pain is a product of higher brain center processing of signals that it has received through the nociceptors. So I hope this is clear. So in nociception, basically, there are 4 types of processes: transduction, then there is transmission, there's perception, and there is modulation. So in transduction, what happens is that it takes these stimuli, which they find, the nociceptors find, and they will convert it into signals. And then they will send these signals. So in transmission, they will send these neurological signals to the brain. And then the brain, the CEO of the company will then think, okay, what do we do with this signal? So the perception, the integration of the neurological signals in the cortex, and then the modulation. So when it goes back, now it went up. Now it has to, whatever goes up goes down, no, especially in pain. So then it will modulate, like okay, I will put some pain reliever thing. So something like chemicals, what our own body does. So they will alter these signals and send it back again to the um, the neurons back again. Okay, so let's talk more about these processes now in detail. So there are three portions rather, for which are responsible for pain. So those are efferent pathways. Efferent pathways are nothing but those receptors which I spoke about, the nociceptors and receptors. They're just the same. They're the same, and they go up. They go to the integration center. They are the post delivery. The post delivery postman of our pain system. Then comes back again the efferent pathways, which is the descending pathways in a system of pain. So now, what are the primary efferents of the body? So now there are the interesting thing about primary efferents or nociceptors, they have a specific function. So every one of there are unique people, like how hairstylists have their own function. I mean, their own job. They are, for carpenter has their own job. So it's like that. So just like that, temperature, touch, chemical pain, itching, hot, cold. So they have their own receptors, their own fibers, which have their own, which are the function basically for the receptors, which is basically the receptors, as in they will take the stimuli. Okay, and furthermore, the fiber class which are there. So now in this fiber class also there are differentiation. There are like 4 types of groups. These are all dependent on the myelin sheet for conductivity. Conductivity as myelin sheet, as in the extra coating around the fibers. Those, and for conductivity as in how fast they are going to take it to the brain basically. So out of which C fibers are unmyelinated. They don't have the sheet around them and they have slower conductivity compared to A alpha fiber, which is completely myelinated, and a fatter fiber. So this A alpha fiber in our body is usually the skeletal muscle proprioceptor. It's basically what helps in moving our joint. And then a delta fiber has a thin myelin sheet around it, which carries the pain and the temperature. Okay, so as you can see that there is a hand over here, the image of a hand right now, and there are like three dots which are there. So I've just put those 3 circle colored dots as a representation of receptors which are already there in our body, around our body. They represent, say, temperature, hot or cold and all. Now, speaking of temperature, basically, there's an interesting thing which occurred, is that recently there's a Nobel Prize winner. I don't know if you have already heard of them. They contributed for the research for this receptors. So David Julius and as you can see, David Julius and Pata Putin, they got the Nobel Prize for the temperature and touch. Now, why am I mentioning this? Is because this is quite relevant when it came to understanding pain and um, the drugs which could be developed because of this research. Now, why is the chili on the slide? Well, they did a simple experiment. They used the chemical from chilies, which is the capsaicin um, chemical, and try to find out what it does to the receptor sites. So before I come to capsaicin, I'll tell you what are the receptors which he found. He found the TRP, which is the transient receptor potential, basically the taking potential, the taking potential of the family. So he found the TRP ion family, and namely they are RTRP-V1, which is the vanilloid channel, which is used for the heat-induced ion. Like I said, there is unique receptors in our body. So out of those receptors, TRPV1 has heat-induced ion channel, because as we are completely filled with chemicals in our body, these are the receptors which control the heat-induced chemical ion channel. And the other one is TRPM8. They are the cold menthol. So he got to know from the menthol condition, using menthol. So it's the cold ion channel in our body. And the lastly is TRPA1, which is a chemical stimuli. Chemical stimuli also have a separate special place in our bodies, which activate sensory neurons to produce acute and persistent pain. And so now capsaicin usually actually binds itself to C fiber, the fiber which is known for pain, and triggers the influx of sodium and calcium channel in our body, and thereby initiate the nociceptive transmission, which I already discussed here. So it's the they transmit, and then they induce ultimately result in pain. So in contrast, but from modulation point of view, the chemicals such as prostaglandins and nerve growth factor, they usually act in depolarizing. They try to close the ion channels in our body. So basically this is the summary of these. Now coming to the main point, how does it go now? Since we already discussed the transduction, transmission, perception and modulation, let's talk about in our brain, how does this all occur, the process. So as you can see, this the big image. So as always, it has to start from somewhere and go to the CEO, which is the cortex. So what happens is that our pain pathway has components, levels, basically. And in the brain also there is levels. So we start with spinal cord. We start from the receptors which go to the spinal cord. And once it goes to the spinal cord, it has it goes to the medulla, and then it goes to pons and midbrain, and then finally the cortex. So these are the cross sections of the brain. So now let's say now we already know now the pain has caused. Okay, so what will happen in this pain? We discussed that there are chemicals. So the chemicals will start releasing. So they'll be released. Now the chemicals are released. So what will happen in this is that they will go and go to the dorsal horn of the spinal cord. They activate, as you can see, the A, delta, or C fibers. They are the input. They will go inside. You're sending the post. They are sending the post um, through the and hold on. So they are sending the post through the spinal cord up till the medulla, where it goes through the pons and then reaches to periaqueductal gray, and then finally to the cortex. Okay, so right now there's some over here. The thing in this is we need to make a note of first order neurons, basically. So in this, as you can see, is instead of overcomplicating it, I made a graph. So you know the primary efferent nociceptors, they take the signal, the painful signal from the receptive field. So now they'll go till the dorsal horn, and what will happen is this is first second order neuron, because first order neuron is down. This is the first second order neuron. So this represents the painful part, like the smaller circle, as you can see, and the green circle, as you can see. So these represent the different receptors in our body which we have. Similarly, there'll be a second order neuron which will also do the same way, except it will be a summation of the primary efferent nociceptors, and they will also go once again to the dorsal horn and become the second order neuron. Now, so the second order neuron will go and enter the thalamus. So you can see the hypothalamus, right? So thalamus is a bit down. So thalamus is so basically it will start acting up, going up to the thalamus of the brain, because the thalamus is the relay station in our body. They will be the managers. They are the managers of the company which we have, and then from there there will be a third order neuron which will correlate to the painful stimulus. So now once it goes up till the thalamus, now a third order neuron usually helps in getting to know the area of the injury, because right now I noted this, but this is actually the patient telling where the pain is. So they can locate the pain and they will know exactly where it is hurting. So yeah, my wrist is hurting and this is the part I am feeling pain. So this is the normal circumstance of pain, by the way. The reason why I'm saying normal circumstance, because you can actually locate the pain because of the whole pain pathway which is happening over here. So now what will happen is that there'll be chemicals. Our body loves chemicals. So there'll be chemicals in our body which will which will be released by the first order neuron to go to the second order neuron and finally the third order neuron. And that chemical I'm just going to mention as substance P. So that is going to be the ascending pathways chemical this. So it goes through the spinal cord, medulla, pons, midbrain, and then finally the cortex. And then later on, we have to go down. So now we are going down, but while going down, it's going through the periaqueductal gray where it will release opioid matters such as endorphins, such as some kind of pain relieving this. So in this process, actually, physios and many others who are exposed to this, they will know pain gate theory. So what happens in pain gate theory is that basically when we zoom into this dorsal horn, basically we are going to be having a opening and closing gate of pain. So over here, as you can see, the first is the gate is closed. Second is the gate because the large fiber inputted. And the thirdly is the small fiber, which is basically what we already said. The small C fiber is opening the gate. So in this, what happens? But in a periaqueductal gray, they release the opioid hormones, and thus through the which will be then stimulating a different opioid neuron over here called encephalin. So now in encephalin, what happens? That's an opioid neuron. It's specifically which will do. So what will do is that it will inhibit whichever neuron is releasing substance P, which is the pain. And two, it will inhibit the postsynaptic neuron from depolarizing and stop the continuation of the impulse to the thalamus, because thalamus is the manager. So they will stop it to go to the manager. So the assistant manager will control the whole process. And this is the overview. And then it will go back again, and then the decision of the reaction will be taken place. So yeah, that is basically the overview of nociception. So this is a case of a 35-year-old Infosys office worker who complains of knee pain. He ran a marathon in Goa River Marathon, and now he reports sharp, aching, throbbing sensation. So this is a characteristic of nociceptive pain, where you can manage it through, and it is quite easier to manage by healthcare professionals. Now, why I'll say easy? Because compared to the other impaired this, it is usually harder. Why? Because I want to talk about this. Now we have already spoke about first and the second order neuron. No, so what happens is they are both two different entities. One first goes to the dorsal, and then the other one starts, and then the third order neuron. But in this, what happens is they join together. So like I said, there are two different locations where you are feeling pain, right? But now they have joined together. So what will happen? When before the pain was being located by the patient, so the patient could tell my wrist pain is hurting, my wrist is hurting basically. But now the area is enlarged, it's amplified. So what will happen? The patient can't tell where it is hurting, but it is hurting, and it is hurting a lot. That whole process is central sensitization, which is basically the amplification of the neural signaling within the central nervous system, which basically elicits pain hypersensitivity. So this could be the conditions which typically have central sensitization are complex regional pain syndrome, trigeminal neuralgia, but also it doesn't need to be a specific other type. It could result with or without potential damage. That's the complexity of central sensitization, because anybody could have it, and it's very painful, which is why so now when we go to the types of pain, we've already discussed nociceptive. What is neuropathic? So I'll go through a brief discussion of neuropathic. It's basically from nerve injury. It's from the name you can understand. It develops from the nerve, and where there are deleterious changes that occur in injured neurons along with the nociceptive and descending modulatory pathways in central nervous system. So now, one thing can be said: neuropathic is not a condition where because one thing can be said: in neuropathic pain, there is no transduction. So there's no converting of receptors. There is only transmission and perception and some part of modulation. So so it doesn't need to have receptors input in it. So that's why the prognosis was, because the injury becomes it's harder to treat because it is without any transduction, because you can treat it through drugs when it's nociceptive pain, or you can treat it through in extreme cases surgery, but you cannot there are many incidences where you can't the prognosis is worse in neuropathic pain, and basically the drugs don't affect it well. The patient who's suffering from neuropathic pain suffers through many failed interventions. This is a carry forward of neuropathic pain. It doesn't always need to be in neuropathic pain. It could be neuropathic pain. So this is basically peripheral sensitization. This is a mechanism of pain where you get higher responsive activity. So the nociceptive neurons, the nociceptive receptors are hyper. They are working hard to go to the in the periphery of this in the periphery basically. When you get a injury, so periphery basically is hands and legs. Usually it is supported with the inflammation, and when you say inflammation, meaning you know that there are a lot of chemicals involved in this mechanism, like immune cells, etc. So we've already discussed the central sensitization. What is nociceptive pain? Basically, this is the third type of pain which I mentioned. So this pain is a altered nociception. It's an altered nociception despite no clear evidence of actual or threatened tissue damage causing the activation of peripheral nociceptors, or evidence of pain or the lesion or of the somatosensory system causing pain. So one example which I can give you is a low back pain. So it doesn't need to have actual evidence. Now you might argue that okay, but we can take X-ray and we can see the changes in the X-ray. Well, no, everybody has evidence says that we can see in every single person the degenerative changes. So you can't assume that that degenerative changes is the result why that person, this individual, is suffering from nociceptive low back pain. Um, it could be because it could be that's why I'm saying this. There's no clear evidence. It's harder to diagnose and to give a specific to see in a diagnostic test basically in nociplastic pain, and usually you can see this in chronic pain patients. So this is a clinical example. So Mrs. Desai, so she's a 41-year-old higher secondary school teacher. She has now applied for sick leave 9 weeks ago due to low back pain. And her main concern was burning and stabbing pain in her back. She has been suffering fatigue and pressure in her low back pain for more than 3 years. However, during the last 5 months, not only has Mrs. Desai's pain intensified, but also the quality of her pain has changed. Now, this coincided with the new examination rules. New examination is in the school rule because she's working in higher secondary school in the pandemic. So her pain was categorized by constant feeling of ever increasing pressure when standing, a burning sensation when bending forward for a short period of time, and a stabbing pain in the low back when lifting objects over 5 kg. Now, what kind of pain do you think Mrs. Desai is experiencing? So as you can see, is she is having low back pain. We don't see any neurological involvement basically in this. You can see, well, there is no radiating pain. So we know that there is no nerve injury in this involved, but she's complaining of burning and stabbing pain. So specifically for the in her back. So now in this, what happens is that this is a chronic condition, definitely. So this is a classic example of nociplastic pain, and which has a nociceptive start to it. So and also, what do you see is something. What do you see specifically? It started when the new examination rules changed, and she's been having this since 3 years. What started before in 3 years was the pandemic. So in this, what happens is that psychological factors play a huge role. But while I say psychological factors, in this, you have to notice that there is it plays a big role in our change in the change in our life, in environment. So we don't know what she's having, what she's experiencing, but we know that she's having tremendous pressure in her lives and all. So while a healthcare individual sees such condition, they should make note that and the patient should also they should educate the patient in this, that firstly, because it was a chronic persistent pain which she's been having, it has now sensitized in her body. So now because it's a longer duration of it, the pain pathways which kept on going and going and going and going and going and going, it became used to it. The brain got used to it, and because of that it got sensitized. And once it got sensitized, it becomes harder to treat now, because now the body only remembers that pain. And so Mrs. Desai now is basically is a tougher participant when it comes to doing pain. So the thing is, there's no one modality in this. There is no two modality in this. It's a whole team which needs to be involved in this. So you cannot treat such patient with a drug, with one drug. It will not treat it. It needs there needs to be a lot of counseling, lot of education, that your pain started through nociceptive pathways, and now that it has become nocioplastic, because there is no evidence of actual threatened tissue damage. um, we will have to go through counseling first, and acknowledge what the patient is going through, and make a suitable treatment plan, and according to her goals and her wishes, not according to yours, because it's her pain which is happening, and her experience, and you can only wrap around the pain treatment according to her goals, because her environmental factors change. So how will she deal with all of this while having pain? And that, through research, has seen, while she gets acknowledged that she's having this pain, and how you wrap around according to her wishes and her environment, this environmental factors, you can definitely see a decrease of low back pain in this, once the counseling and the physiotherapists and the physicians and the um, different other healthcare individuals and the caregivers support. So I want to tell and introduce this mime. So while everyone says, the whole society says, wow, pain lets you know you are still alive. So what will the neuropathic pain sufferers, what will the nocioplastic pain sufferers and those who experience central sensitization feel? They will be like, man, I feel so alive right now, because there's so much of pain. So now I've already gone through the reason why I said that this pain education needs to be told to patients, is because you need to have a positive approach to the intervention, because most of these patients, they have a negative they're already in a negative mindset, because they will have lot of sadness, lot of the, fear and apprehensiveness. So how do we tackle it? Because you cannot treat a patient or anyone who's suffering through pain by saying it will get solved in one session, or a drug or a surgery. Because not what I want to mention here is that while osteoarthritic, giving an example basically. So now osteoarthritic patients, they are most of the times referred for knee replacement surgery, but does it really affect in reduction of pain? The reason why they are giving for surgeries for reduction of pain, but many of times it actually worsens. So we need a multidisciplinary intervention to see, until they are educated about all the pathways which are going through in our body, until they are receptive for the positive, receptive for the education of the pain, to understand what they are going through, after their counseling, which is very important. After their counseling and most of this, if their pain doesn't decrease for at least 2 scales down, then you can go through for the surgery. Otherwise it is not worth it, and you will definitely affect your quality of life. And also more research opportunities. I would encourage whoever is watching, and those who will watch this in future, please try to post more research this, and try to read more about it, because this is a big, interesting, and a huge topic, and will definitely help in managing pain, because there are a lot of pain conditions where pain could be managed in a different way, but because conservative management is not a thing which not a method which will help in this whole pain area, because you need to look at in a outer way. What I would add is, look at it as though you are seeing an elephant blindfolded, because you're going to be only touching a part of a elephant, where the elephant is if suppose you touch the elephant's ear, but you're blindfolded, so you don't know it's the ear, so you will say it is oh, it is the finger or the hand or something. It's basically like that, so you don't know it's actually a big elephant. But um, every different healthcare or different person will think, oh, this is one thing. So you need to remove the blindfold and step back and see the bigger picture in explaining pain and managing pain. So one of the thing which I would like to recommend, the books Explain Pain is a really good resource by Lorimer Mosley, which patients can refer to, and Pain for Healthcare Professionals by Hubert. They are good resources to read on pain. And with that, I will take up the questions. So with that, I will, yeah.
Thank you, Dr. Palasha. It was very in-depth and very informative. I want to request Dr. Riddhi to please take over.
Yeah, good morning, everyone. So the first question is, what type of pain is that from trigger and tender points?
Trigger and tender points is nociceptive pain. They are the painful stimulus which you get it in, which the receptors take up, basically the primary efferents, and go go therefore. Henceforth, all the ascending and descending pathways occur. So that is a typical representation of nociceptive pain. Also, there's another question. Do you any type of pain in the body should be considered as, do any pain type of indicator for severe underlying condition, and can pain be a good indicator for diagnosis of a condition? That it's a good question. So any type of pain considered for indicator for severe underlying condition? Yes, it can be. Example, neuropathic pain. It could be an underlying condition for a tumor. It could be it could cause through them. There are rare cases where tumor would be found in your pancreas, a type of tumor where it could actually impinge the or basically damage the nerve or any part of our body, and it often gives a radiating, sharp shooting pain. And while the patient tries to find a solution for this. It is often not seen. It is often rejected and seen as just a neuropathic pain, when in reality, unless you do a higher diagnostic test, you will not understand that there is actually a tumor, and it could be life threatening as well. And is pain a good indicator for diagnosis condition? Definitely. You can definitely indicate pain for diagnosis of a condition. So currently, what one thing I'll give an example of a simple example of um, your low back pain. So pain over here is an indicator for telling it's a low back pain, but why? Because the one of the only symptoms is pain over here. I'm talking about non-specific low back pain, and in non-specific low back pain, usually the person suffers from nociception pain. Um, Nociplastic pain, because it's non-specific. There is no specific induced reason for low back pain, but it is a condition and it should be treated seriously as well, just as the rest of this. Because when the pain will hinder you from your day-to-day life, will stop you from living your life, your quality of life, and which comes down because of pain, that is good enough to take it seriously and treat it just the way you see it, because it's not making you live your life as it is, how you want it to be. So that is how we can you recommend a very reliable tool for assessment of pain, and can we use the same for nociception cases? That's a good question. So according to research, there are many different tools actually for different kinds of pain. So the most used tool, which is easily available and non complicated, is the visual analog scale, especially with 1 to 10. So you can tell, and especially for people who don't understand, um, geriatric patients or pediatric patients. So like for them, you have faces, which gives frowning, happy, and irritation. So it's easier for them. That's a reliable tool for the assessment of pain. But there are other reliable tools as well, such as Start Keeley, the Keeley tool, which is there, which was done by Keeley University in UK. So that was mainly for the low back pain. There are different tools for assessment tools for there are assessment tools for the other kind of pain, such as neuropathic pain. But in general, if you want to tell one tool, then it is a visual analog scale. But while you take as a tool for the assessment of pain, I recommend you to see the two other tools which are there for like short form 56 and as such. So you can take a shorter questionnaire to check their quality of life as well, because quality of life and depression and anxiety scales for chronic pain as such needs to be evaluated along with the pain, and we need to acknowledge and see how hopefully the patient will be more honest when it comes. Give them space when they are doing this, because let them tell how much it is, what in general it is, so their quality of life or depression anxiety scale. So can we use the same in nociplastic? Yes, we can use it for nociplastic as well. all these tools are very much useful for nociceptive cases as well. So one thing which could be told is use your biopsychosocial model. So in biopsychosocial model is you see the biological way, that is your individual assessment, your physiotherapy assessment. Use the psychological assessment, where you assess the depression, their quality of life, their anxiety, their fear, frustration. And then assess the social part. So most of these psychological questionnaires, they have these aspects where they will tell about their social life as well. One including, I will say, is those who are spiritually influenced as well. So though I will include that biopsychosocial spiritual as well, because spiritual does affect the condition. So in the beginning when I said, right, the pain is influenced by cultural and environmental and this. So culture, religion, it also affects the pain. So you need to see how much it is affecting the condition of the patient. So that is also a factor, and you need to measure and to see. Basically in this, it'll be a quality talk, it'll be an interview, and motivational interviewing basically, where the patient and you will talk about the biopsychosocial, well, not the biological, but the psychosocial and spiritual, cultural aspects of their lives, and you need to note it down because that is very much relevant in treating your patients, and you will definitely notice a change in their pain scale. You will definitely notice, because I'll give you a case. I'll tell you a case what I noticed. So in my area, I was treating back pain and osteoarthritis. So there were two patients, an osteoarthritic patient and a back pain patient. Now, in the back pain patient, all she needed was to evaluate. She had a typical nociceptive representation, and she there was no diagnostic relevance. There was just pain. She couldn't walk properly. She couldn't get up. She was the patient was dependent on the family members to get up. So in this process, you assess the whole part of it. So who are there in the patient family and what the patient is going through, what happened prior. So you will be the diagnostic team of house, the series house, so how they diagnose all this. So you have to know that is actually relevant in the pain this treatment. And once you get to know okay, the bigger picture, you can tell the management cases, what management strategies, what you have already established, and then you can get a success rate better. In osteoarthritic, in osteoarthritic case, what happens is that there's a lot of pain in osteoarthritic conditions, lot of pain. So what pain do you think in osteoarthritis there is? There is nociceptive pain because it originated from a tissue damage, and there is central sensitization mechanism playing in place, because now most of the times they can't locate the area where it is hurting. It's hurting a lot, but it is usually they can say this area of my knee is hurting, this area, but which point? So this is a proper case of central sensitization, and central sensitization is very hard to treat. So you cannot treat with painkillers with this. They can help you, but they will not help. They will not treat the pain. So in this case, what you will have to do is that you have to go into the educative aspect of the patient and tell the patient, this is your condition. So your condition has this symptoms. Now these symptoms are causing this type of pain, and which is why the pathway has these are the pathways which are going through, and now these pathways are amplified because of central sensitization. So we will need your cooperation. So then they will understand, they will cooperate better, they will want to participate more and try to be an active participant. So active participant is a bigger thing, and listen to their pain complaints carefully. So as you had mentioned, collective intervention across stream for treatment which is lacking. Can patient make a difference by evaluating it themselves in some way or the other? So it is, what you can do is that the patient can, there are a lot of available resources online. You can definitely, and lot of healthcare individuals are available straight across your screen in different ways or the other. Your local physios, your local doctors, they are all active now on the digital platform. So go to the, because physiotherapy and physicians and psychologists and caregivers, their own families, they play a huge role. So they all contribute a point, they all contribute a component in treating all of this. So the patient can do is, while evaluating, as in they can do a thing called as educating themselves in this in the condition. They can educate themselves through what type of pain they are facing, because like I said, it's not a debit transaction, it's a credit transaction, and a continuous credit transaction. So the when they educate that, okay, so well, now I'm having this pain, and I will try to cope with it cope with it. So they will go and ask the assistants, and they can do home exercises, and their own, they can take a step forward and doing motivating themselves in getting motivated that, okay, now I know that drugs are not going to affect, because in neuropathic pain, NESDs don't get affected. So such type of drugs, they are not going to affect your pain. You're getting a lot of neuropathic pain, you're getting a lot of central sensitized pain, but none of it is working. So the only way to do is to cope. So how can you cope is through the other allied health professionals, and you can talk to your doctors, as in different doctors we have now, like occupational therapists, physiotherapists, and psychologists. So so they will all play a role in something called as cognitive behavioral therapy. So lot of behavioral therapy is needed to change your viewpoint on what kind of pain is you're facing. And because brain is a powerful CEO, and once you tell the brain, okay, I'm going to live with this. I'm going to live with this, and I'm going to make a change in my life, and going to live better no matter what. So while being in a better, while having a positive mindset towards safer way of doing it, so there are a lot of pamphlets as well available, so they can use it to evaluate and treat, which can be done conservatively by themselves. There are a lot of physios which help through physios and all, which help in this process. So they can do it on them by themselves, but they need a lot of therapy and therapy in this. Like they need a motivational counseling, motivational interviewing in this. So yeah, that's about. Any other questions? Okay. Yeah.
Thank you so much, Dr. Palasha. I want to request Dr. Gauri to please present the vote of thanks.
Hello, good afternoon, everyone. Thank you, Dr. Mamta, for giving me this opportunity to express vote of thanks for this webinar session. So myself, Dr. Gauri Kamatwag, take this opportunity to present vote of thanks. First and foremost, I would like to thank the speaker of today's webinar, Dr. Palasha Sardesai, for giving a very insightful session for us on this topic, pain education. I hope it was helpful for all of us because we could see the topic as a whole through professional and patients' perspectives as well. Thank you so much, Dr. Palasha. I would request all the attendees to stay tuned because we would be shortly coming with the second part of the series. I also take this opportunity to thank Dr. Nagaraj, who was technical host for this session, for giving your continuous support throughout the session. I also take this opportunity to thank our whole IIP Women's Cell Goa team for putting in efforts for making this webinar successful. I also thank our central IIP team for giving this platform to us, for which we could conduct this webinar and many more series to come. Thank you so much. And last but not the least, I would thank all the attendees for being proactive and participating in the webinar. Have a pleasant weekend, everyone. Stay safe. Thank you.
Thank you, everyone. Have a beautiful weekend. Thank you, Dr. Gauri.
Thank you so much, Dr. Gauri. Dr. Nagaraj.
Yeah, ma'am. Thank you all. We'll end the session.